Chapter 4, Articular System and Arthrokinematics. So this chapter is covering the joints of the body and how those joints move. Joints are the articulation between bones or where bones join together. They provide an important function to allow motion and provide stability, which are two things that kind of work opposite to one another. The more mobility a joint has, the less stability it has, and vice versa. So the balance between mobility and stability is determined by the shape and the structure of the joint. We have two main types of joints. Synarthrosis joints are designed for stability. That's why they all start with S. Diarthrosis joints are designed for mobility and movement. The amount of mobility a joint has is determined by the number of axes of rotation that joint has. For our synarthroid joints, which are joints for stability, we have two types. Fibrous synarthroid joints are for sutures and ligaments and gomphus joints, and cartilaginous synarthroid joints can have a fixed disc or a non-fixed disc. Fibrous synarthroidal joints include sutures and have a thin layer of periosteum with a jagged edge between the bones that allows the shape of the bones to kind of interlock. We see examples of this type of joint in the sutures of the skull. Ligamentous synarthroidal joints are fixed joints that are joined by ligaments or an interosseous membrane, like the one that we have running between our tibia and our fibula, or the one that spans between the radius and the ulna. These joints are also known as syndesmosis joints. Gomphosis joints are another type of fibrous joint that are seen where our teeth connect to the jaw, kind of like a peg in a socket. Cartilaginous synarthroidal joints allow for small amounts of bending, twisting, and compression. Our most common example is going to be within the spine, where each vertebral level is designed for stability, and the mobility of our spine comes from the collective motion at all of these levels. These cartilaginous joints are joined by hyaline or fibrocartilage, and they have a fibrocartilage disc that can be fixed like in the spine, or it can be non-fixed like in the TMJ. These joints are also known as amphiarthroidal joints. Our diarthroidal joints are designed for mobility and are also known as synovial joints. I would be pretty familiar with this picture for your testing purposes, but this picture shows you what a diarthroidal or synovial joint looks like. Synovial joints have no direct union between the bone ends, so we have a joint space with synovial joints. And these joints are surrounded by a joint capsule. The internal surface of the joint capsule is lined with the synovial membrane, and the joint itself is filled with synovial fluid, which lubricates the joint and provides nutrients within that joint space. Each end of the bone of a synovial joint is lined with articular cartilage, and these joints are supported by ligaments. How much movement a joint has is based on how many axes of rotation or degrees of freedom the joint has. Non-axial joints have no axes of rotation or degrees of freedom, but may have a slight gliding motion that occurs between the two bones, such as what we see in the carpals of the hand or the tarsals of the feet. Uniaxial joints move in one plane of motion about one axis, so have 1 degree of freedom. These are typically described as hinge joints because they can only move in one plane, such as flexion extension of the elbow. We also have uniaxial pivot joints, where one bone surface pivots or rotates on the other, such as the radius rotating on the ulna for pronation and supination. We also have this with C1 on C2 for cervical rotation. Biaxial joints have two planes of motion about two axes, and so have 2 degrees of freedom. We can see an example of this in the MCP joint of the fingers. Where your hand meets your fingers, you have the metacarpal phalangeal joint, which can move in both flexion and extension, which would be 1 degree of freedom, and then ab and adduction, which would be your 2nd degree of freedom. The CMC of the thumb is a special biaxial joint that is shaped like a saddle. This sellar joint has bone that is a concave surface and a convex surface on the same side of the joint, depending on how the joint's moving. So as you can see in the picture here, the CMC of the thumb is shaped like one saddle on top of the other, allowing for things to fit together like a rider in a saddle. Triaxial joints give us 3 planes of motion about 3 axes, meaning that they have 3 degrees of freedom. So we have flexion, extension, ab and adduction, and rotation at these joints. These joints are designed for mobility, and our most common examples are going to be the hip and shoulder. To make up a joint, we obviously have to have the bones that join together, but we also have ligaments and a capsule that support the joint. The ligaments are made up of a fibrous connective tissue that help to support and join the joint, connecting bone to bone. Ligaments are non-elastic, meaning that they're not meant to stretch. They can be capsular, meaning that they run into the capsule and make up a part of the capsule, like we can see in with the hip in the iliofemoral and pubofemoral ligaments. Or they can be intracapsular, meaning that they run within the capsule. The capsule surrounds and encases the joint. The outer layer is fibrous, and the capsule works to protect and support the joint. The synovial membrane lines the inner layer of the capsule and is made of a thick vascular connective tissue. The synovial membrane produces synovial fluid, which serves to lubricate the joint, provides nutrients, and shock absorption. Synovial fluid is made of water and dissolved protein and is a lot like the consistency of egg whites. Surrounding the joint are bursa, which are small pad-like sacs that are meant to decrease friction of the tendons that run around the joint to cause motion at that joint. Cartilage is a dense, fibrous connective tissue that is designed to withstand pressure and tension, and we have a few different types of cartilage within the body. Hyaline, or articular cartilage, covers the ends of bones and synovial joints in order to create a smooth surface. This cartilage lacks blood and nerve supply and can't repair itself, so it needs to be protected. Fibrocartilage can be found in both synovial and cartilaginous joints, so joints that are designed for both stability and mobility. Fibrocartilage is designed to provide shock absorption, and we have several examples found in our body. So the meniscus of the knee is made of fibrocartilage in order to alter the shape of the knee joint and improve bony congruency. The labrum of the shoulder and the hip is made of fibrocartilage and acts to deepen the joint cavity. We also have discs like our intervertebral discs that fill gaps between bones, so we can find those between the vertebrae of the spine, but we can also find discs between the ulna and the carpal bones filling in the gap present there. Elastic cartilage is meant to be flexible but return to its normal shape, like the ear. So you can bend and twist your ear, but when you let go of it, it's going to pop back to its normal shape. Tendons are the connective tissue that connect muscles to bone and come in various shapes, including cylindrical cords or flat bands. They may be encased in a tendon sheath, which is a sleeve-like structure that surrounds the tendon to help reduce friction, working with the bursa at the joint level. An aponeurosis is a broad, flat, tendinous sheet of connective tissue where the muscle belly fans out into the tendinous material. Examples of aponeuroses in the body include the thoracolumbar fascia, which is where your latissimus dorsi fans out across your lower back to attach to the pelvis, and the linea alba at the midline of your abdomen, where each side of rectus abdominis meets. End feel is what the therapist feels when moving a joint to the end of its range of motion. It's defined by the sensation perceived when passively moving a patient's joint to the end of its range of motion. But the important thing to note here is that end feel is about what you as the therapist are perceiving, not what the patient is feeling. End feel is used to determine the reason for range of motion limitations. It can be normal, meaning that the therapist feels at the end of range of motion what is expected for that joint in that motion. Or it can be abnormal, meaning that what is not expected to be found stopping range of motion at the end of that joint and that motion is what the therapist perceives. And that can be indicative of pain, swelling, muscle guarding, and changes in anatomy. In order to assess a patient's end feel, the joint must be moved to the end of the patient's range of motion and then given a gentle overpressure to determine what type of end feel the joint demonstrates. Without the gentle overpressure, we cannot perceive end feel. Our normal end feels include soft, firm, and hard. Soft end feels occur when we have compression of soft tissue or muscle bulk that halts motion, such as with elbow flexion, where the bicep contacts the forearm, limiting the elbow from bending anymore. Firm end feels result from tension in structures around the joint that limit motion and has a slight give at the end of the range of motion. So I want you to think about stretching a muscle across a joint and the slight give you feel when pushing deeper into that stretch. That's what a firm end feel feels like. Most end feels in the body are firm, and hard end feels have a hard or abrupt limitation of motion as a result of bone contacting bone. These joints have no give when you push at the end of the range of motion, so you want to think about elbow extension, where it's just a hard block. Abnormal end feels are end feels that we would not expect to occur without injury, no matter which joint or motion they're associated with. Empty end feels have no resistance to movement, but the therapist is told to abruptly stop motion, typically as a result of pain felt by the patient. When we get an empty end feel, we associate that with pain being the limiting cause of motion. Boggy end feels are soft or spongy. You can think about how you squish into mud when you walk through a swampy area, and that's similar to the perception for boggy end feels. This type of end feel indicates swelling. Muscle spasms are reflexive guarding, where you feel the muscle resisting range of motion. Muscle spasm end feels are associated with acute injury when muscle guarding is occurring, trying to protect the area that was injured. And a springy block is an abnormal end feel that indicates an internal derangement, such as torn cartilage invading the joint space, and causes the joint to reach end range and kind of spring back a few degrees out of that end range because the resistance there pushes it back to where it shouldn't be felt. We'll work on assessing different end feels on each other in lab in class. Remember that joint structures contribute to the balance between mobility and stability. Most joints in our body are ovoid joints with a concave-convex relationship, meaning that one surface bulges out while the other caves in to accommodate the larger bone, just like you can see in this picture. One bone is often larger than the other, contributing to the need for the convex and concave surfaces. The saddle joint is a special joint where each side of the joint has both a concave and convex surface. This is what gives our thumb the mobility that it has because this is the type of joint located at the CMC of the thumb. Flat joints have limited motion and are found between the carpals of the hand or the tarsals of the foot. Joint surface congruency is the degree to which joint surfaces match or fit together. Oftentimes, joint surfaces will be congruent in one position, but incongruent in all of the other positions. Joint structures are also typically taut in the congruent position and more lax in the other positions. This is why joint positioning at the time of impact or injury is important in determining which tissues or structures are going to be implicated. When looking at joint congruency, we talk about the closed pack and the open pack positions. The closed pack position is the most congruent position of the joint segments, so where the segments match up the best, and the joint is slightly compressed because things match so well. This is the most stable position of the joint, and it's used to test capsule and ligament integrity, since these joint structures are also most taut in the closed pack position. The open pack position is the position with the least congruency of joint surfaces, the greatest amount of joint space, and the laxity of the joint structures such as the capsule and ligaments. The open pack position is less stable, but it allows for mobility of the joint, and I'd highly recommend that you study the closed pack and open pack positions in Table 4.3 on page 52. Clinically, we need the closed pack positions for testing integrity of joint structures, and we need the open pack positions for applying joint mobilizations. Arthrokinematic motion is the movement that's happening at the joint surface. So we've talked about osteokinematic motion, which describes how the bone moves, and those terms include our flexion, extension, abduction, adduction, and internal-external rotation. But arthrokinematics are the movements happening at the level of the joint surface. Arthrokinematic motions do not happen on their own or voluntarily, but they're the result of osteokinematic motions happening. At least one arthrokinematic motion occurs with every osteokinematic motion, and our three arthrokinematic motions are roll, glide, and spin. So breaking those three down a little bit more, roll is what happens when a new point of one surface touches a new point of the surface it is touching the whole way through the motion. So think of a ball rolling down an incline. You can see in this picture with the lines marked that a new point of the ball is coming into contact with a new point of the incline throughout the entire motion, allowing the ball to roll down the incline. Comparing that with a glide or a slide, with gliding or sliding, we have one point of contact on one surface coming into contact with new points on the surface it's touching. So the moving object is maintaining its singular point of contact with new points on the opposite surface. We can see in this picture here the one point on the base of the square comes into the contact with the different points of the incline as it slides down the incline. And our last arthrokinematic motion, spin, happens when a singular point stays in contact with a singular point on the opposite surface. Spins are the least common to happen in the body. Most of the time you're going to see a combination of a roll and a glide. The concave convex roll is a tough one, and so I encourage you to utilize whatever resources you need, whether that's coming to have a one-on-one conversation with me, watching some YouTube videos, pulling out a skeleton, creating your own models, whatever works to help you understand this. But the concave convex roll helps us to understand what arthrokinematic movements are happening during an osteokinematic motion. The first step is determine which side of the joint is moving and which side of the joint is fixed. So if it's the concave surface that is moving, such as an open chain elbow flexion, the concave surface will roll and glide on the fixed convex surface in the same direction as the distal end of the bone. So during elbow flexion, from anatomical position, the forearm is moving anterior, and so we understand that the concave ulna is rolling and gliding anteriorly on the fixed convex humerus during elbow flexion. We can also look at the opposite orientation of that. So if we have a convex surface moving on a fixed concave surface, such as what happens during shoulder abduction, the convex surface will roll in the same direction as the distal end of the bone and glide or slide in the opposite direction as the distal end of the bone. So looking at shoulder abduction, we see the arm move superiorly, so we know that the convex humerus is rolling superiorly in the same direction, but then gliding inferiorly in the opposite direction on the fixed concave scapula. And these rolls and glides happen in order to keep the bony surfaces in approximation. We will practice this in class, and you will have to determine this for different joints throughout the course for your exams and in different lab activities. So some steps for determining the concave-convex roll in relationship. When determining the direction of arthrokinematic motion, determine which joint surface is moving. Then if the joint surface or the moving joint if the joint surface of moving limb segment is concave or convex, and then is the limb segment in an open or closed kinetic chain configuration, because that's going to help us understand which direction the rolls and glides are happening in. Accessory movements are motions that occur at the level of the joint and are needed for normal motion, but are not voluntarily produced either. We'll talk about them more in the chapters on the muscular system and biomechanics, but we want to touch on them here. So some terms to be familiar with: traction or distraction is the act of separating the ends of the joint or pulling them apart. We apply traction before we apply joint mobilizations. In contrast to traction, we have approximation or compression, which is pushing the two joint surfaces closer together. Common joint pathologies this chapter touches on includes dislocation, which is a complete separation of our joint surfaces. We can compare that with subluxation, which is only a partial dislocation. Osteoarthritis is the wear and tear arthritis that breaks down the articular cartilage on the ends of those bones and produces osteophytes that invade the joint space. Sprains are tears of the ligament. Strains are tears of the tendon, because tendon starts with T. So if we remember that muscles taper into tendons before attaching to bones, we can see strains in the muscle belly or the tendon, but it is important to associate strains, ST strains, with tendons, and sprains, SP sprains, with ligaments. We can also see inflammation of any of the joint structures. Inflammation is a normal response to injury, and as such, we can see diagnoses such as tendonitis, which would be inflammation of the tendon; tenosynovitis, which is inflammation of the tendon sheath, often due to overuse or repetitive use injuries; bursitis is inflammation of that fluid-filled sac around a joint that serves to reduce friction, but because of their role can become irritated and inflamed, and so we can see inflammation of the bursa because of the repeated friction that produces bursitis. And then capsulitis is inflammation of the joint capsule. When we have involvement of the joint capsule, we see a capsular pattern, which demonstrates a characteristic pattern of motion loss depending on the joint. So it makes things predictable for us. Capsular patterns help us to predict how the restriction will progress and how we can manage the patient's treatment. Examples of capsular patterns include for the shoulder, we see a loss of external rotation followed by a loss of abduction and then internal rotation. At the wrist, we see equal loss of flexion and extension, and at the knee, we see more loss of flexion than we do extension. So to wrap things up before you come to class, I want you to write down any questions that you had over this lecture so that you can bring them to class and be sure to ask them, because if you have a question, I'm sure somebody else does too. And come to class in appropriate lab attire, prepared to assess end feel and arthrokinematics.